Hello everyone, I am myself Dr. Rajesh Guba. I am the General Medicine Educator. In this session, I'll be doing a quick recap on this topic of hyperosmolar non-ketotic coma. So, this hyperosmolar non-ketotic coma, you need to know in which type of diabetes this hyperosmolar non-ketotic coma is commonly seen. Hyperosmolar non-ketotic coma, it is commonly seen in type 2 diabetes mellitus. This hyperosmolar non-ketotic coma, it occurs even there is presence of increased quantity of insulin. See, why am I saying this? You take diabetic ketoacidosis. This is the acute complication in type 1 diabetes mellitus. This diabetic ketoacidosis, it occurs mainly due to decrease in the insulin, whereas hyperosmolar non-ketotic coma, which is more common in type 2 diabetes mellitus, is seen in spite of excess amount of insulin. So, this hyperosmolar non-ketotic coma, what exactly are the characteristic features? They are characterized by severe hyperglycemia. The blood glucose levels may be in a range of 600 to 1200 milligrams per deciliter. And we are using the word hyperosmolar non-ketotic. What does that mean? That means that the ketone bodies are absent. Right? That means that the ketone bodies are absent. What are the ketone bodies? Acetone, acetoacetate, and then the beta hydroxybutyrate. These are the ketone bodies. So the ketone bodies are absent in these patients with the hyperosmolar non-ketotic coma. And what are the precipitating factors for hyperosmolar non-ketotic coma? The precipitating factors include non-compliance with the treatment. So the individual is advised to take adequate oral hypoglycemic agents, but the individual is non-compliant with the treatment. And along with that, inability to drink sufficient water to keep up the urinary losses. Then followed by that, this hyperosmolar non-ketotic coma, it is commonly seen in elderly diabetics living in nursing homes. So the precipitating factors are non-compliance with the treatment, inability to drink sufficient water, and it is commonly seen in elderly diabetics. Next, followed by that, what are the other precipitating factors? That includes infections like urinary tract infection or pneumonia or gastrointestinal infection, stroke, that is cerebrovascular accident or myocardial infarction. Then administration of the steroids. Steroids, they increase the gluconeogenesis. So in type 2 diabetics, taking steroids which will increase hepatic gluconeogenesis will predispose the individual to develop the hyperosmolar non-ketotic coma. And the individual on immunosuppressant drugs, because individuals on immunosuppressant drugs, they are more prone for infections, and infections can precipitate the development of HONC, and other drugs like diuretics. So, and which particular diuretics mainly? That is thiazide diuretics, right? Thiazide diuretics. So these are the precipitating factors for the development of HONC, that is hyperosmolar non-ketotic coma. Then after which therapeutic procedure hyperosmolar non-ketotic coma occurs? HONC can occur after a therapeutic procedure such as hemodialysis or peritoneal dialysis. It can occur after the tube feeding of high protein formulas or high carbohydrate infusions. So in these scenarios or after these procedures, there is development of the hyperosmolar non-ketotic coma. Next, followed by that, what is the pathophysiology of hyperosmolar non-ketotic coma? The pathophysiology involved is profound dehydration resulting in sustained hyperglycemic diuresis. That will be the pathophysiology of the hyperosmolar non-ketotic coma. That is profound dehydration resulting from sustained hyperglycemic diuresis. Now, what will be the clinical features in patients with hyperosmolar non-ketotic coma? See, glucose is not being utilized by the cell. The individual will have weakness, and this glucose will undergo the osmotic diuresis that will make the individual to develop polyuria, then polydipsia, lethargy, confusion, and development of convulsions and as well as coma. So these are the clinical manifestations that can be seen in patients with hyperosmolar non-ketotic coma. So the CNS manifestations, that is convulsions and coma, are very important. Now, how do you diagnose HONC, that is hyperosmolar non-ketotic coma? First and foremost, very important, the blood glucose levels, they are very high. They are in the range of 600 to 1200 milligrams per deciliter. And along with that, there is high serum osmolality. Right, there is high serum osmolality. And in these individuals, let me tell you, the ketone bodies are negative. Right, the ketone bodies, they are negative. And how do you calculate the serum osmolality? See, the serum osmolality in milliosmoles, it is calculated by this formula. 2 into sodium plus glucose divided by 18 plus blood urea nitrogen by 2.8. So this is how you will calculate the serum osmolality. So what is the normal serum osmolality? The normal serum osmolality, it is around 285 to 295 milliosmoles per kg. Okay, so that will be the normal serum osmolality. And in patients with HONC, there will be increase in serum osmolality. And will there be metabolic acidosis in hyperosmolar non-ketotic coma? See, in diabetic ketoacidosis, we have seen that there can be severe acidosis. Why? The ketone bodies, they are acidic in nature. In case of hyperosmolar non-ketotic coma, there will be mild ketoacidosis, right? Mild ketoacidosis, mild metabolic acidosis in the absence of the ketosis, right? And even there is pre-renal azotemia. And this pre-renal azotemia is the one which will predispose to the development of mild metabolic acidosis. And why there is pre-renal azotemia? That is because of dehydration. The individual will develop pre-renal azotemia. There is polyuria. Because of polyuria, there will be decreased renal perfusion resulting in pre-renal azotemia. Now, how do you treat the hyperosmolar non-ketotic coma? See, the treatment for hyperosmolar non-ketotic coma is that you need to give the IV fluids, that is, the half normal saline should be given, right? Half normal saline should be given. Followed by that, you need to give the insulin, and the insulin that you will supplement is the regular insulin, right? The insulin that you will supplement is the regular insulin. So that is a treatment for hyperosmolar non-ketotic coma. So please remember, hyperosmolar non-ketotic coma is the most common acute complication seen in type 2 diabetes mellitus. Thank you very much.